Good afternoon. I'm Avery Vail. I'm from the Overlake School. I'm a rising senior, and I did a literature review on the efficacy of conventional MIS TLIF versus robotically assisted MIS TLIF in patients with degenerative spinal diseases. First off, I'd like to introduce the subject with a little case study. So we have a 44-year-old Caucasian woman with a spondylolisthesis and lumbar spondylolisthesis. So what this means is that there is a defect or fracture in the vertebral arch, along with a slipping of the vertebrae at the L4, L5 area. We can see this here, right about here in that circle. You can see that's out of line. That's where that slipping is. Additionally, there's osteochondrosis at the L5, S1 region, and that's basically joint disease. This patient has several risk factors, including the fact that she's on several painkillers and blood pressure medication, and she has a reasonably extensive history of different surgeries and medical conditions. To rectify the spinal issues, she underwent a 2-level TLIF surgery from L4 to S1. Well, what's a TLIF? It's an acronym for a surgery that's called transforaminal lumbar interbody fusion. It's basically a surgery that's used to fuse spinal vertebrae together. The way it does this is by removing the disc between the vertebrae and replacing it with a bone graft and a cage. This cage allows the bone to grow in between the vertebrae, effectively combining them into one solid piece. The surgeon accesses this through what's called the transforaminal space. That's the, let me show up right here. Yep. And from there, the surgeon will have to resect parts of the lamina, even the spinous process, and along with both the superior and inferior facets. This treatment is used to resolve degenerative disc diseases and has typically a 2 to 4 day recovery period. Circling back to our case study, this patient postoperatively had a number of complications, including implant failure with cage dislocation. So we can see right here, that cage is very far out of where it should be. And additionally, the architecture of the rod dislocated and the S1 screws were dislocated as well, which you can see right here. So if you look pre-revision and post-revision, you can see they're quite different in both of those areas. This caused a number of symptoms for the patient. Significant pain, muscle tension, and even paresthesia, which is basically a numbness or tingling in certain parts of your body or on the skin. So they had to undergo revision and repair surgery to basically resolve this. And overall, this is a pretty long and risky process. So circling back to my actual research, the purpose of it was to determine through a survey of existing literature whether the usage of robotically assisted MIS TLIF, which is basically minimally invasive TLIF, so basically instead of an open surgery, it's a 4-centimeter incision given by or guided by X-ray, and comparing that with comparing the robotically assisted version that does use X-ray with the conventional fluoroscopic X-ray MIS TLIF procedure. And this is important because proponents of robotically assisted surgery have proposed that robotically assisted surgery could reduce the risks of patients during procedures and possibly result in better outcomes. So that means for patients who would normally have similar experiences like our case study patient, robotically assisted surgery is theoretically capable of mitigating that risk. Well, how do we define efficacy? Well, the 6 metrics I used, visual analog score is basically a rating from 0 to 10 typically. That's basically a way for doctors to gauge pain. Oswestry Disability Index, I'll refer to that as ODI, is basically a measure of inhibition, or basically the amount that their daily lives are impacted by lower back pain, along with blood loss, operative time, discharge days, so how long they're in hospital overall, and complications they experience. So here's my methodology. I'll go through it very quickly. Start off 2 search queries, filtered out irrelevant titles, abstracts, etc., and focus on institutional retroactive studies. I also want to make sure the studies were statistically sound because of time constraints, I won't be able to go into the studies in depth. So just understand that I did the due diligence, making sure that they're statistically decent. My hypothesis was that robotically assisted MIS TLIFs will, because of their greater precision, will potentially have less blood loss, more accurate screw placement, and therefore resulting in less post-operative pain. And then on top of that, there'd be fewer complications and better patient outcomes. However, the novelty of the robotically assisted surgery could potentially mean that there are longer operation times due to the learning curve and operators' lack of prolonged training. So first metric, once again, this is a measure of pain post-operatively and preoperatively, but for now we're going to focus on the 6-month follow-up between these two studies. So on the left here we have the robotically assisted surgery, where the average post-operative, pain rating was 1.8, whereas the traditional minimally invasive TLIF was at 2.33. So what does this mean? Well, I basically took the data, broke it down, and did a 2-sample t-test to determine whether this was statistically significant. And the measure of whether it's significant or not was a p-value of under 0.05. And as you can see from the table on the left here, the p-value is 0.473, so it's significantly higher than that 0.05. So because of this test, and there's no statistical evidence to suggest that these outcomes are different in regards to postoperative pain 6 months after follow-up. This was corroborated by a study that I found that did the exact same idea. They determined that there was no significant differences between VAS scores between the two procedure types. Regarding ODI, a similar study also broke down and compared the two types of procedures, and they did that preoperatively 3 days after and 2 years after. And once again, the bar for significance was less than 0.05 as a p-value. Now, each of these numbers is quite similar as you look down from here, but especially when we look at the 2 years after operation, we see that all these p-values here on the right, they are significantly higher than 0.05. So at each step in this process, there's no difference between ODI values between these two procedures. So there's no statistical evidence to suggest that there's any difference in outcomes in this metric. Now, regarding blood loss, operative time, and discharge day, this is where things are going to get a little messy. First off, regarding operation time, here we see relatively similar, 121 as the minutes for the operation time, compared to 147. And standard deviations overlap, so reasonably similar. Not a little bit different from what I hypothesized. However, it gets even more interesting when we look at blood loss and day of hospital, where robotically assisted surgery had 291 milliliters of blood loss, compared with conventional surgery, which was 66 milliliters. So radically different. This is further built upon by the hospital length stay, which was 180 hours for robotic surgery and 43 hours for conventional. Now, this is so different from my hypothesis, I wanted to break this down even further and look into this. So upon further examination, I found this study that found the opposite of the previous information regarding operative time, where it found that actually robotic surgery added 43 minutes of operative time on average. However, it should be noted that the use of instrument tracking by robotics and not full robotically assisted surgery did decrease the time as well. However, it also did find that there was no significant difference between the discharge day and that the learning curve was actually very minimal in robotic surgery. So another element that was very different from my hypothesis. Furthermore, when we look at blood loss in this study, and this study claims that there was less operative blood loss in robotic surgery than conventional surgery. So, and there are also non-significant differences between operative time and discharge day. So fortunately, when we look at complications, it gets much more straightforward. There's no statistical difference in the outcomes in terms of complication rates between the two kinds of procedures, as we can see from the p-value of 0.999 on the right. So what does this all mean? Do we know which one's do we know which one has a greater efficacy? No, because on 3 metrics, they're almost comparable. They seem to be both very effective. However, when we're looking at blood loss, operative time, and discharge day, it's all over the map. No, I mean, there's no consistency. And there's probably a few reasons for that. I mean, first off, these are from surgical studies, which are infamously known for having low sample sizes. And this problem is exacerbated by the fact that it's a very new technology. You know what I mean? This is not something that's been heavily written up on, and it's not a technology that a lot of surgeons are familiar with. So there's probably a lot of human variance here too. So what are the next steps? Well, first off, we have to clean up some of these metrics. We got to look into blood loss, operative time, discharge day a lot further and get some actual cohesion here. Additionally, this is a very this technology has a lot of potential, and we know that because the potential yield of precision is something we haven't seen before. That's something that humans can't do. I mean, it allows us to have reduced X-ray exposure for surgeons. So theoretically, we're not just seeing better outcomes down the line for surgeons in terms of less radiation exposure, but potentially for patients as well. So in order to determine this, however, there needs to be more metrics, including pedicle screw accuracy, radiation exposure for surgeons. So we're getting both sides of that. And we're also looking into larger sample sizes, larger population, getting more data out there. And we're also looking at information that's further down the road. When we see the next generation medical students who have really grown with this technology, have a lot of experience with it, I wouldn't be surprised if the outcomes are very different than the current generation because they weren't trained on this technology. So that's generally what I have. And here are my references. And thank you, Dr. Pierre and SSF for this opportunity. Thank you to my fellow research interns for feedback and all support. And thank you for listening. I know I went pretty quick. There's a lot of stuff to cover. So if you have any questions, happy to answer.
All right, I'm just giving everybody a moment to step up here. But that was excellent. I think you demonstrated a very good grasp of the research process. It was very organized. It is far more organized than the one that I submitted this morning. So great job on that.
Thank you.
In 15 years or 19 years after you finish your orthopedic spine training, are you going to do robotically assisted TLIFs or are you going to do non-robotically assisted TLIFs?
I think it's... Obviously, I haven't got the medical school yet, so I can't specify what I'll probably do. But the way I see it is I think it's naive to ignore the progression of technology. Technology is always moving forward, and if we don't see the opportunities that we're given, we're missing those opportunities, and we're potentially not saving lives or potentially not helping the patients more than that we can at the moment. So obviously, we'll have to wait and see how this progresses over time, what studies come out, and what information we learn. But we're seeing everywhere else in medicine, in all of the world, being heavily introduced to robotics, AI, and all these new technologies. And I think it's naive to say that we won't be progressing with it. And I had the opportunity actually, or we all did during the fellowship course, to put a few screws in on a cadaver using robotic surgery, and that was the most incredible experience I've had in my life because I was able. You never get the opportunity to put a screw into a dead body. You don't, know what I mean? And I was able to do that with robotic guidance, right? And I have no training, no expertise whatsoever. I'm just some 18-year-old kid who just who was curious about it. So if I can do it, who's to say that this can potentially help surgeons down the road at a far greater possibility than all the training that we go through now. So yeah, hopefully that sort of answered your question.
You did. Great job. Thank you. Yeah.